Welcome to Impact Education's PayerTalkCE program, navigating the complexities of hypertrophic cardiomyopathy, payer considerations on strategies for comprehensive management. I am Steve Calusi. I'm the principal consultant with Calusi Consulting LLC, and I am very excited to be here with you today. Today's program is jointly provided by Medical Education Resources, Inc. and Impact Education LLC, and it's designated for 0.75 contact hours of continuing education credit. This activity is supported by an independent educational grant from Cytokinetics, and we'd like to thank them for their support. At the conclusion of today's program, you'll be able to complete an evaluation which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity, and once you complete your evaluation, you must click Claim Credit to download your certificate, or for pharmacists, submit your credit to the CPE monitor. Hypertrophic cardiomyopathy is a complex condition where evolving clinical evidence, treatment options, and coverage considerations intersect. In this discussion, we're going to explore how current HCM guidelines inform diagnosis and management, what they mean for payer coverage policies and clinical decision support, and how newer pharmacologic therapies fit into care for patients who remain symptomatic despite first-line treatment. We'll also examine the role of shared decision-making in HCM and discuss opportunities for managed care professionals to support patient-centered care by enabling access to individualized testing and treatment options. And we are so pleased to be welcoming Dr. Nosheen Reza, a cardiologist and nationally recognized expert in inherited cardiovascular disease. Dr. Reza is an assistant professor of medicine at the Hospital of the University of Pennsylvania and the Perelman School of Medicine, where she practices within the Penn Center for Inherited Cardiovascular Disease and the section of Advanced Heart Failure Transplantation and Mechanical Support. She also serves as director of the Penn Women in Cardiology program, bringing a strong focus on patient-centered care, advanced therapies, and multidisciplinary collaboration to the management of complex cardiovascular conditions. Dr. Reza, welcome.
Thanks so much. I'm delighted to be here.
Fantastic. So before we dive into treatment and policy considerations, can you briefly describe hypertrophic cardiomyopathy and why it's important for payers to understand?
Sure. So hypertrophic cardiomyopathy is a genetic heart disease that's characterized by abnormal thickening of the heart muscle, most often the left ventricle, the major pumping chamber to the body. And this abnormal thickening causes several things. It impairs filling of the heart with blood that can cause what we call outflow obstruction or left ventricular outflow tract obstruction. And this can lead to symptoms like shortness of breath, chest pain, heart arrhythmias, and reduced quality of life. We estimate it affects about 1 in 500 people, thought to be pretty rare before, but now we're realizing is actually pretty common. And it's often underdiagnosed or diagnosed late in life after many of the complications have already occurred. So for payers, it's important to understand that HCM is a chronic, lifelong condition. The majority of people actually do very well without life-limiting symptoms, but of course, this proportion does have symptoms and potentially adverse outcomes. So it's important to understand that there's a highly variable presentation and, of course, resource utilization because of this. And early recognition and guideline-aligned management and treatment can improve symptoms, reduce downstream procedures and hospitalizations, and, of course, support more predictable and value-based care over time.
That is very interesting. And, I think you highlighted a number of points that are very relevant to payers, right? And one is this idea that rare conditions that were once thought to be rare, as surveillance improves, we are learning that they are not as rare. That becomes very important for the payers to recognize, right? Because that puts these conditions on their radar. You mentioned it's a lifelong condition and there's substantial resource utilization. It's a variable presentation. All of these things add to the challenges for payers. So this is a very timely and very relevant discussion for payers to be a part of. So can you walk us through what's changed in the most recent HCM guidelines and why those updates matter for health plans?
Absolutely. So the newest updated United States guidelines for hypertrophic cardiomyopathy management were released in 2024, combined with the American Heart Association, American College of Cardiology, and other societies. And these are our current most clinical recommendations. So we'll walk through several of the newest updates that I think matter for health plans, as you discussed. So overall, to reemphasize how we make the diagnosis of HCM, that's based on seeing an unexplained thickness of that left ventricle that we talked about earlier of 15 millimeters or more. That threshold is actually 13 millimeters or more in somebody that has a first-degree relative of HCM or somebody with genetic testing that is suspected to be the cause of HCM. We assess this wall thickening by echocardiography or cardiac MRI. So as you just mentioned, the evolution of these imaging technologies are going hand in hand with detection of the disease. And then genetic testing is, of course, still recommended for patients with either a confirmed HCM diagnosis or to help elucidate the cause of the left ventricular wall thickening, to facilitate family screening and inform prognosis and risk assessment as well. Other things that are important in the guidelines that have some updates that are relevant include how we assess and risk stratify for sudden cardiac death, an important outcome that we want to avoid in HCM, of course. We now use, and what's recommended is the American Heart Association Sudden Cardiac Death Risk Calculator and Risk Assessment. That helps us estimate the 5-year sudden death risk and mortality rate. And that's, of course, important during what we call a shared decision-making conversation for primary prevention implantable cardioverter defibrillator placement. And this is more of a shift towards this concept of individualized risk assessment using validated risk tools, rather than sort of how we used to do this before, is checking the box on the presence or absence of traditional risk factors. The major update for the 2024 guidelines are introducing this new class of therapy for obstructive HCM, which are called cardiac myosin inhibitors, as an option for patients with symptomatic obstructive HCM. Now, we'll talk about the two different kinds of HCM today, so let me just rewind and review that. Obstructive HCM is this concept of having left ventricular outflow tract obstruction when you have that setting of increased left ventricular wall thickness, and we measure the pressure gradient across that obstruction, and you're defined as having obstruction when that pressure gradient is 30 millimeters of mercury or more, and we likely suspect that you have severe symptoms or symptoms with HCM when that gradient becomes 50 millimeters or more. These numbers are relevant because they help us guide these therapies that we'll talk about. So historically, our first-line therapies for the symptomatic left ventricular outflow tract obstruction type of HCM included beta blockers or non-dihydropyridine calcium channel blockers. But in the 2024 guideline update, the guidelines recommend all of these equivalently, sort of across what we call a class 1 recommendation. And those include adding a myosin inhibitor in adult patients only at this point, adding disopyramide, which is a historical therapy we used to use as an add-on as well in when patients had symptoms despite beta blockers or calcium channel blockers, or septal reduction therapy, which is septal myectomy or alcohol septal ablation performed at experienced centers. So this is a major update from the previous guidelines, which did not include myosin inhibitors. And at the time these guidelines were published, this really reflected the FDA's approval of mavacamten, the first-in-class cardiac myosin inhibitor. And then recently, just in December 2025, the FDA approved the second-in-class myosin inhibitor called aficamten as well. And then moving on to sort of talking about this concept of shared decision-making, what's really unique, and again, in these guidelines is we have all of these therapies now available, and they're provided really with that same level of evidence suggesting that the second-line therapy for symptoms after beta blocker and calcium channel blocker can be considered very similar. You can choose myosin inhibitor if that's what's relevant for your patient. We can go to septal reduction therapy if you think that's the better option after a shared decision-making conversation, or you can escalate with disopyramide therapy.
Well, there's a lot to unpack there. Thank you so much for that overview. You talked about shared decision-making. I do want to come back to that in more detail a little bit later, the cardiac myosin inhibitors. and obstructive versus non-obstructive disease. I think let's start with the non-obstructive piece, because I think this is more of a quick point for us to talk about before we dive more into obstructive disease. What about the management of non-obstructive HCM? Is there new guidance there?
Yeah, it's a great comment, because we have really had a dearth of therapies available for non-obstructive HCM at this point. This is really the place where we need the most innovation and development of new therapies. But in the new guidelines, there was an important update for the management of non-obstructive HCM. And again, that's defined by having this left ventricular wall thickness, but in the absence of that left ventricular outflow tract gradient, less than 30 millimeters of mercury. And the newest guidance is based on a trial that was done with valsartan, of course, an older drug that we typically use for high blood pressure treatment. But this was tested versus placebo in a trial called the VANISH trial recently. And what this trial showed us is that for patients who are younger with non-obstructive HCM due to a disease-causing cardiac sarcomere genetic variant and a milder phenotype, meaning the disease hasn't really fully manifested yet, but we have a little bit of increased wall thickness, valsartan may be beneficial to slow adverse cardiac remodeling. And again, that is based on emerging evidence suggesting that potentially valsartan and drugs in its class, like angiotensin receptor blockade in early stage HCM, may halt progression of disease. This is given a weaker recommendation in the guidelines because it's just based on that one trial. But again, something that's newer that we can offer to our patients.
That's really interesting. And one of the things I can say from the payer perspective is that it's always reassuring to see older therapies being repurposed for new uses, because it's nice when these generically available medications that have been on the market with proven safety and efficacy in many other conditions can find new life. So what are you doing about patients with HCM who develop heart failure, and is there anything really new to offer them?
Yeah, this is a really important population that certainly needs a lot more investigation into therapies, both old and new. So particularly this population that develops heart failure can be very diverse in how that disease process progresses. But if we define heart failure as a left ventricular ejection fraction of less than 50%, which is how we define this in HCM, and that's different than how we define it in all comers with different types of cardiomyopathy. The important thing to know in these guidelines is that they recommend discontinuation of the cardiac myosin inhibitors in this setting. And of course, caution with people even initiating them in patients who may be progressing to heart failure. But this discontinuation recommendation really reflects the mechanism of action of cardiac myosin inhibitors, which ultimately reduce contractility of the heart. And then if you're in a setting where you already are developing decreased contractility, you obviously don't want to have a drug on top of that to further decrease that function of the heart. And the guidelines reiterate essentially using what the 2022 United States heart failure guidelines recommend in terms of therapies. We call them guideline-directed medical therapies for heart failure, other device-directed therapies for heart failure in a very similar way in this HCM population. So not a whole ton of new innovation, but of course important reminders as these new therapies are being incorporated.
Excellent. Thank you so much. All right, so I want to talk a little bit more about the pharmacologic therapies that we touched on briefly. So from a clinical perspective, how is HCM typically managed pharmacologically, and what should payers understand about the role of medications across the disease course?
Yeah, we'll focus on obstructive HCM. As we talked about, this is where the most innovation and changes in therapy recommendations has taken place over the last few years. So historically and currently in the guidelines, beta blockers are generally considered first-line therapy for symptomatic patients with obstructive HCM. And then non-dihydropyridine calcium channel blockers, verapamil or diltiazem, can be substituted, or sometimes practitioners will add them to beta blockers in the case that the single therapy is ineffective or intolerable. And we judge the success of this therapy based on the patient's symptom status rather than a certain number a reduction of the gradient. So patients need to tell us that they do feel better, whether that's assessed by a clinician adjudicated scale, a patient reported outcome tool. But again, that's how we really define success of treatment. And the guidelines tell us that for patients with persistent symptoms, despite beta blockers or calcium channel blocker treatment, that's when we revisit that algorithm we discussed earlier that can include progression to cardiac myosin inhibitors as a next step, disopyramide, which used to be the historical next step, in isolation, or proceeding to septal reduction therapy. So cardiac myosin inhibitors represent a real paradigm shift in HCM management because they're the first class of therapy that really target the underlying mechanism of HCM disease, that underlying sarcomere hypercontractility, rather than simply reducing the heart rate or contractility sort of non-specifically the way that beta blockers and calcium channel blockers are used to do. This new class of medications, the myosin inhibitors, are developed specifically to treat the cellular pathophysiology of HCM. And now we have this evidence base based on the clinical trials that have been done to offer patients alternatives to historically, when we got to this point, patients would have to proceed with septal reduction therapy. So either an open heart surgery or other invasive procedure. And so we can really see that this new class of medications has really changed the landscape. Patients may never proceed to needing a septal reduction therapy procedure at this point. The whole progression stepwise through these therapies may be different for every individual across the life course.
Fantastic. And I think that you touched on this already, but it sounds to me that targeting the underlying disease is maybe changing the way that we are thinking about treatment just beyond symptom control.
Absolutely. As we discussed before, and historically in HCM, symptom control was really the focus. And we sort of referred to the treatment of symptomatic HCM as palliative before, in a sense, because it was symptom directed. And we didn't really have anything that we knew would work to arrest the progression of disease or change the heart in any way, even potentially reverse the effects of HCM. And I would say that whole landscape is really opened up now in the age of cardiac myosin inhibitors and targeted therapies that are directed at the disease mechanisms. So in obstructive HCM, this mechanism is targeting cardiac contractility, and therefore what the trials focused on and what we focus on when titrating patients on these therapies are reducing this left ventricular outflow tract obstruction. And again, this is fundamentally a different disease mechanism than beta blockers and calcium channel blockers and how they interacted with the HCM heart muscle. And our guidelines give us this class 1 recommendation for patients who have obstructive HCM and persistent symptoms that we think are due to LVOT obstruction, despite beta blockers or calcium channel blockers. And again, giving us this new option to proceed with a different kind of therapy. And I think what we're seeing beyond left ventricular outflow tract obstruction and symptom improvement, many of the follow-on studies from the cardiac myosin inhibitor clinical trials and exploratory studies have also showed us that we may be actually remodeling or changing the HCM heart in a positive way, meaning that the other complications of HCM, like diastolic dysfunction, that's the problem that the heart has relaxing in HCM. These measures are also shown to be improved with cardiac myosin inhibitor therapy. And so these sort of potentially, you might consider them off-target, quote-unquote, effects of the drugs, though not specifically LVOT gradients, but again, really attacking the whole entire disease mechanism and downstream consequences of what happens in the HCM heart. This is a huge new development in patients and our treatments for patients with HCM. So it's really exciting. And we have, of course, a lot of work to do to see how long these positive changes stay that way, how long patients may need to stay on these therapies. And of course, that work is ongoing. But again, a lot of new, not just conceptual advances, not just theoretical advances, but real life practical advances for our patients and their symptoms.
That certainly is exciting. And I appreciate you highlighting the data gaps that we have right now. And I'll ask again from the payer perspective, payers really care about comparative efficacy and safety to other agents that are used in this same disease area. And so do we have data that show us how the myosin inhibitors compare to other existing treatment options, beta blockers, et cetera, for HCM?
Yes, actually, just last year, we had the first head-to-head trial of a cardiac myosin inhibitor and beta blocker monotherapy. That was called the MAPLE HCM trial, and that directly compared aficamten monotherapy to metoprolol monotherapy in 175 patients with symptomatic obstructive HCM. And this was, again, a groundbreaking trial because it was the first randomized evidence comparing a cardiac myosin inhibitor alone to beta blocker alone. The trial duration was 24 weeks, and like many of the prior clinical trials in cardiac myosin inhibitors, the primary endpoints were focused on what we call feel and function. And the function endpoint is a measurement of the peak oxygen consumption, or the peak VO2, that's performed on a cardiopulmonary exercise test. And at 24 weeks, aficamten demonstrated at 2.3 milliliters per kilogram per minute greater improvement in the peak oxygen uptake compared to metoprolol, which actually caused a decrease in the peak oxygen uptake. So again, the first time that this kind of evidence has really ever been shown head-to-head, and again, demonstrating that aficamten does improve functional capacity in patients with HCM, in addition to reducing the left ventricular outflow tract gradient and improving symptoms. So moving on to the feel endpoint, patients who received aficamten in this trial also experienced significantly greater improvements in New York Heart Association functional class, Kansas City Cardiomyopathy questionnaire scores. Of course, we measure LVOT gradients. These trials also measure cardiac biomarkers of stress or stretch, like NT-proBNP levels. And then, as we were talking about earlier, markers of diastolic dysfunction or adverse cardiac remodeling. One of these endpoints we're measuring is left atrial volume index. And all of these things, again, significantly improved with aficamten compared to metoprolol. So again, this was a really groundbreaking study that suggested that cardiac myosin inhibitors provide clinical benefits beyond what can be achieved with beta blockers alone, even though historically we've been using beta blockers for decades for this indication. So really providing us with evidence to rethink this sequential paradigm as data continues to grow in this space.
Wow, thank you so much for that overview. I have a couple follow-up questions for you. And the first is, I wrote down 2.3 milliliters per kilogram per minute, greater improvement in peak oxygen uptake. From a clinical perspective, is that clinically significant or just statistically significant?
We believe it to be clinically significant as well, based on prior studies of cardiopulmonary exercise testing in patients with HCM. The historical data tell us that every 1 milliliter per kilogram per minute improvement in peak oxygen uptake is a significant reduction in the likelihood of progression to heart transplantation in patients with HCM. So then you scale that again to this 2.3 mils per kg per minute improvement. So that's telling us, although we're not talking about heart transplantation as an outcome in these specific trials, that difference in your ability to improve your cardiopulmonary fitness, again, is a mortality benefit down the line.
Thank you so much. Yeah, that's really interesting. I think from the pharmacist perspective, not everybody will be an expert in reviewing the outcomes of these clinical trials. So understanding what is quote unquote clinically significant from a clinician's perspective is really valuable insight. Another follow-up question that I had, we talked earlier a little bit about shared decision-making and how that could potentially influence treatment and testing choices for patients with HCM. Now, we know that we have two options, mavacamten and aficamten, on the market now, But the question then comes up, how does shared decision making play into the selection between these agents as well, but then also on top of that between the beta blockers and everything that we had just covered as well?
Yes, the 2024 guidelines really position shared decision making as a class 1 or strong recommendation for all patients with HCM or those who are at risk for developing symptomatic HCM when developing a plan of care. And that shared decision making concept extends not just to the pharmacological therapy, but several critical treatment and testing decisions in HCM management, including offering genetic testing, implantable cardioverter defibrillator placement and risk assessment, advanced therapies for LVOT obstruction, as we've talked about, and even things like participation in competitive or high intensity exercise. So this is really reflecting this concept that choosing the quote unquote right therapy for your patient may evolve throughout that patient's life course. And it should be a conversation between, of course, the patient and the clinician to assess what that patient needs at that particular point in their life, and then keep renewing that data as their annual surveillance testing is done or the disease progresses in any way. And so the guidelines provide this framework for selecting against and amongst these therapies, pharmacological, device, and otherwise, of course, taking all the data together. We just reviewed the limited head-to-head data that we have in this space for largely a lot of the pharmacological therapies. So, of course, there are many different factors that will go into the selection of a therapy. So, for example, individual patient response, tolerability, emerging real-world evidence, and all of these things, I would say, clinicians consider when choosing which therapy is best for their patient. So we know that there are particular pharmacologic and pharmacokinetic differences in the two of currently available cardiac myosin inhibitors. I think broadly I can say that aficamten has a shorter half-life when compared to mavacamten. So that allows for more rapid dose adjustments. And again, these dose adjustments are based on echocardiography measurements, similar to the way that mavacamten was released with this REMS protocol. But the pace with which you can change the dose and titrate the dose is quicker with aficamten, given these different pharmacologic properties. And I can give you sort of one example of how this really plays out in real clinical life. So I have a patient who developed hypertrophic cardiomyopathy, which was found to become symptomatic after a lung transplant. And so for a long time, his care was focused on the lung transplantation aspect, and he made it many years after his lung transplant, was very stable, but then had recurrence of this shortness of breath. And so while a lot of the initial workup was focused on the lung, we ultimately figured out that no, it was actually due to severe symptomatic LVOT obstruction. So given his severity of symptoms, he loved to go bike riding for many, many miles at a time, and realized progressively over the years he couldn't reach the same distances that he used to. And he really missed that aspect of his life. And so wanted to proceed with a more definitive therapy that would help him restore his prior functional capacity. So at that time, given everything to consider with his medical treatment, his prior surgery for a lung transplant, our shared decision-making conversation arrived at septal reduction therapy with alcohol septal ablation as his best option, to try to get a one-and-done procedure, if we could do it, to reduce those severe gradients and avoid another cardiothoracic surgery, because he'd already been through one of those. And at that point, medical therapy had obviously been tried, but had failed to improve his symptoms to the degree that he wanted. Fast forward a few years, and it's a not uncommon story, but the obstruction has returned. He's symptomatic again. He got a few good years out of that first alcohol septal ablation, but again, the symptoms are back and he's looking for another fix. And so now we have these new therapies available to us. And for him, we've talked through the now 2 available cardiac myosin inhibitors. And one other aspect of between the 2 that's helpful to differentiate for this patient in particular, and of course other patients that may be similar, is other drug-drug interactions and the way these 2 molecules are metabolized. So we know they're both metabolized through the CYP system. Mavacamten was required through the REMS program also to have monitoring for CYP genetic variations that affect drug metabolism. We believe that aficamten has fewer of those drug-drug interactions. And so for this particular patient, for example, he's interested not in another procedure, but potentially a medical therapy that may help restore his quality of life. And given his many medications he takes for immunosuppression for his lung transplant, we are looking and hopeful that aficamten, when available, will help improve those symptoms and his quality of life. So that's the next therapy we're looking for. So I tell that story as an example of how the availability of therapies, how the progression of somebody's symptoms and their disease obviously can change the way that you offer these therapies. And somebody may look at this and think, well, that's completely out of order. You've gone from septal reduction therapy now to a cardiac myosin inhibitor. But I would say this is real life. This is actually how this goes for a lot of patients.
That is fascinating and such valuable real-world experience that you bring to the conversation, Dr. Riza. Thank you for sharing that. And I think, you are seeing the patients on the front lines. This is always a consideration that we have from the managed care perspective, which is how can we, as managed care pharmacists, develop policies that better support that individualized patient-centered care while keeping in mind our goal of, utilizing our limited healthcare resources as judiciously as possible.
Yeah, of course, a very important point. I would say to understand that hypertrophic cardiomyopathy is a highly heterogeneous disease, and one of the biggest opportunities for managed care is to align policies with that understanding and that clinical reality, like the example we just discussed. Rather than a one-size-fits-all approach, utilization management can be better supporting patient care by recognizing differences in disease phenotype, symptom burden, prior treatment response when evaluating therapy options like cardiac myosin inhibitors and those that may come in the future. Another key opportunity is shifting from episodic authorization and more towards longitudinal care. So these therapies, as we've briefly mentioned, require ongoing monitoring, dose adjustments, close follow-up, and coverage policies that facilitate that kind of continuity rather than repeated administrative barriers can, of course, improve safety and effectiveness. Benefit design also matters. So high cost sharing or unclear coverage criteria can unintentionally steer patients towards a therapy that may be less optimal for them or potentially more invasive and maybe not needed. And so transparent, predictable coverage that supports decision-making, as we've talked about between patients and clinicians, is really a key in HCM, especially because this quality of life is often our primary treatment goal. And then there's opportunities to really look ahead and potentially partner with experienced HCM centers, look at real world data to refine these coverage decisions over time. And we're really in an age where targeted therapies are exploding. So this evidence base for these therapies is going to continue to grow. And so adaptive and data-driven policies that can help ensure access is both appropriate and hopefully will be sustainable as this landscape evolves.
Fantastic. Thank you so much for that overview. And looking ahead, what is important from your perspective for payers to understand around improving care and testing and treatment for patients with HCM?
I would say a few things. So looking forward, improving HCM outcomes will really require a few parallel strategies. So first, as we discussed, HCM is still underdiagnosed and many patients experience long delays before they reach an accurate diagnosis. And so we need to facilitate earlier and more consistent recognition and get patients to an HCM experienced team and seen at a comprehensive HCM center at least once. So that means improving clinician awareness, standardizing evaluation pathways, supporting use and appropriate use of echocardiography, cardiac MRI, and genetic testing, all of these tools that are important in not only the diagnosis and prognosis, but longitudinal care of patients with HCM. And then going off of that, it is true, we need longitudinal team-based care in HCM. So as we've talked about throughout our time today, HCM management is not a single decision point. It's an ongoing symptom assessment, risk stratification for sudden death, management of comorbidities, iterative treatment decisions. And so strengthening multidisciplinary HCM programs and care coordination is really key. Third, I would say as new therapies become available, like cardiac myosin inhibitors and others that may come in the next few years, we need care models that support safe implementation. There are clear protocols for initiation and titration, so we need access to monitoring, ability to expediently read these studies, return results to patients, and make the decisions about their next step with drug titration, and to help make these shared decision-making goals so that we can reflect both what the guidelines say and what our patients voice to us. And then finally, I think building real-world evidence and pragmatic research will help us refine which patients benefit most from which therapy, how to sequence these therapies, how to potentially better improve outcomes that matter to patients, including both the feel and the function.
And Dr. Riza, you alluded to a really important point that I think matters to our audience, and that is therapies that might be coming in the future. Can you give us a possible peek into the pharmaceutical pipeline?
Oh, there is certainly a lot to come in both the obstructive and non-obstructive HCM landscape, so I'll try to give you a broad overview. I think what we're most excited about in the early 2026 timeframe will be the release of the primary results of Acacia HCM, which is the trial of symptomatic non-obstructive HCM and the use of aficamten versus placebo in that population. So really highly anticipated trial. Hopefully we'll hear the results early this year. There are a lot of other non-myosin inhibitors that are under investigation in obstructive and non-obstructive HCM. There are ongoing studies of SGLT1 and 2 inhibition in both of these populations. There have been early phase studies in different kinds of myosin modulating compounds in, again, both of these populations showing real significant benefit in gradient reduction. And so again, follow-on studies certainly to come, progression towards phase 2B and 3 trials we anticipate. There are, of course, other mechanisms not targeting the myosin apparatus, but moving towards this phase of myocardial energetics, a new point of interest in HCM. And so there are compounds that are shifting the mitochondrial and metabolic energetics back and forth between fatty acid oxidation and glucose uptake. These are being tested in both cardiometabolic phenotypes and also non-obstructive HCM. So a lot of data out there, a lot of data to come, everything from gene therapy that's being done in first-in-human clinical trials all the way up to now phase 3 studies that we're hopefully anticipating hearing more about this year. So it's a really quickly evolving and exciting landscape.
It is certainly an exciting landscape. I don't want to lose focus on the fact that we do have a newly approved therapy that you had mentioned, the aficamten, that is also bringing excitement, but not just for what it is currently approved for, but also the highly anticipated study results that you mentioned in non-obstructive HCM. I think that's going to be really interesting to see as well. And so, Dr. Riza, as we wrap up, what key takeaway would you like managed care and clinical stakeholders to keep in mind as they work together to improve access to guideline-aligned and patient-centered care for people living with HCM?
The key takeaway is that HCM is a chronic heterogeneous condition, and the best outcomes come when access and policy are aligned with clinical expertise. When managed care and clinicians work as partners using transparent guideline-based criteria, reducing avoidable administrative friction, and supporting longitudinal monitoring and multidisciplinary expertise, I'm sure we can improve both patient experience and the value, and hopefully clinical outcomes. So I think our goal is simple: get the right patient to the right test and the right therapy at the right time, and measure success in not only utilization of these therapies, but in symptoms, function, quality of life, and cost.
I couldn't have said it better myself. Thank you so much, Dr. Riza. And I would now like to open the discussion for Q&A from the audience. And I think what we'll do is hop on camera here. Dr. Riza, thank you again for the great discussion. We do have a couple questions from the audience here, so I'll just get started. This first question is, how does disopyramide work?
Yeah, absolutely. Great question. So disopyramide actually works, I'll give you the molecular basis first. So it blocks cardiomyocyte sodium channels and thereby interacts by decreasing the sodium calcium exchanger in the cardiomyocyte, which ultimately downstream leads to decreased intracellular calcium and decreased contractility of the heart. And thereby it's one of the drugs that we call a negative inotrope. And so thereby, that's why we use it for obstructive HCM. By decreasing the inotropy or contractility of the heart, we can reduce LVOT obstruction. There are a couple of important things to know about treatment with disopyramide in patients with obstruction. Number one, it actually does have some pro-arrhythmogenic capability. It can actually accelerate conduction through the atrioventricular node, and thereby it is really not allowed to use it without a beta blocker or calcium channel blocker in combination. So you really should never see it used in isolation alone for obstructive HCM or really any cardiac disease because of that quality. And then another thing that is common that we encounter are this drug's side effects. So there is a strong anticholinergic property to the drug, which results in urinary retention. Constipation are often the most common issues that we see in our patients, especially in our older populations. And these occur at quite a high frequency, somewhere between 10 to 20% quoted in the literature. And so we often have to co-prescribe and other medications to relieve the constipation and urinary retention side effects. For some patients, it is tolerable and they can, for example, make diet and lifestyle modifications to overcome these complications. But again, for some, we'll try these therapies potentially in a period of time where symptoms have worsened, or we're trying a new combination of therapies, and ultimately those side effects end up being too much for the patients to tolerate. So then we, of course, have to adjust our therapy after that.
Fantastic. Thank you for that insight. And the next question here is, what are the most common reasons payers deny prior authorizations for cardiac myosin inhibitors, and what clinical documentation has been most effective in overturning those denials?
Yeah, unfortunately or fortunately has been common, but I think it's becoming less common. But I think it's important for clinicians and other folks involved in this arena to sort of know exactly how we think about making sure our patients, again, as I mentioned earlier in the session, are getting the right therapy at the right time for them. And so some of the more common things we see are just maybe omitted. Maybe these have gone through the clinician's thought process, but just haven't made it down into the paper chart or the electronic chart just quite yet. But it's sort of things like reasons why the patients haven't been able to tolerate the other first line therapies as addressed in the guidelines, so beta blockers or calcium channel blockers. And so, for example, a clinician may look at a patient's EKG, see their resting heart rate is actually already low on their current potentially low dose of those therapies, and they've made the clinical determination that they are not able to increase the dose of the beta blocker or calcium channel blocker any further due to this risk of bradycardia or further conduction abnormalities. And so they will then say, I think for this patient, it's best that we move to a cardiac myosin inhibitor instead of continuing to increase the dose of those other two medications. But oftentimes we see perhaps that thought process has not really made it explicitly into the chart. Or, for example, there are in the REMS protocol and the other prescribing guidelines for the cardiac myosin inhibitors, there's not really really truly explicit documentation about how to handle exercise provoked gradients. So we talk about resting gradients and Valsalva, which is again a way to measure provoked gradients with a resting echo. But oftentimes what we do as clinicians is also test out how patients are feeling on the treadmill, because it's the most realistic way to simulate their exertion and their exercise and their daily symptom burden. And so we will sometimes use exercise echo gradients as well to really help us assess what kind of therapy the patient needs. And sometimes those gradients can get sort of all mixed up, whether it's a resting or a Valsalva or an exercise, just not clearly documenting where the data comes from. So I think to maximize chances of success, what we try to do in our clinic, of course, is just really put our thought process down very explicitly about what is the baseline therapy the patient's on, what is their New York Heart Association class, their functional status on that therapy, basically how are they feeling, what are the reasons that we are electing to change our therapeutic paradigm, whether it's to a different drug or to an invasive procedure, refractory symptoms, refractory LVOT gradients, for example, and just really having that all laid out in detail has been really helpful for us.
Yeah, that's fantastic. I will say from the managed care pharmacist perspective, having that data laid out as clearly as possible always speeds up the process from our end as well. So thank you so much, Dr. Riza, for the fascinating discussion today. And I'd now like to conclude the podcast and thank everybody for participating today. Once again, I would like to thank Cytokinetics for their support on this educational activity. To claim credit for the activity, please click the complete evaluation link in the activity. And once the evaluation is complete and submitted, then you'll be able to select the type of credit that you require. And that will conclude our program today. Thank you so much, everybody, and have a great rest of your day.